Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am joined by my two splendiferously spectacular, super co-hosts, Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello, I love being splendiferous.
I know. I love like a whole new word that you invented just for us. Splendiferous.
Pretty much. And spectacular can go in all different directions because my favorite variation on spectacular is actually the exact opposite, which is craptacular, because I feel like it really conveys a particular sentiment that is very helpful.
I like that word. Yeah. There's definitely times when that word applies for sure.
Yeah.
A few times this week, I think, actually.
Yeah, probably.
So Carrie, I understand you got a hole in your head this weekend.
I did.
Yeah. What exactly does that mean?
So
you're here talking to us, so nothing's seeping out anywhere.
that you can see.
Well, that's true.
So kind of on a whim, I was taking a small human being to get her ears pierced. And I have been flirting with the idea of getting like an upper ear piercing for a long time. And just never actually did it because you have to find the place and it's got to be reputable. It's got to be clean and blah, 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 blah,
Yeah.
blah, blah. And so I had done all the work for small human. And I'm like, okay, well, now I trust it and I'm here. And apparently there's an entire Instagram world about curating ear piercings. And so I dove into that world and I'm like, yeah, I'm going to get, it's called a flat piercing, which I didn't know until I got into this. And so it's right up here on this part of the ear, kind of the upper outer. It's not the actual helix that's curved up. It's exactly what it sounds like. It's the flat part. And so I did it and I'm very excited and very pleased. And now that I got one, I kind of want to get more.
Is it just a stud or is it like a little loop that goes around?
It's just a flat stud that's kind of that curved shape, and it keeps rotating around because I had to put a longer post on it so that if there's swelling right after it, like,
well,
I
had an older human older child human, a young woman. How's that? I guess you classify. And she had one of those and it like kept like having all this serous drainage. And anyway, finally, after about a year, it got okay. But she kind of was regretting it almost for a while there, but it's worked out now.
Yeah.
So hopefully you don't have that problem.
They take a long time to heal. I mean, pretty much everything I read said anywhere from 3 to 12 months. And so I'm assuming that
it's an area that doesn't have like great blood supply. So anyone that does not have great blood supply is going to take a while to heal. I even learned that I had this mole on my leg, on my lower leg, biopsied, and they had to like cut it out and sew it, and it took forever. And I'm like, it's not like I have like peripheral vascular disease or smoke or have diabetes or anything, but I was just like, dude, that's serious stuff. Like I can understand, especially with older people or people with other medical issues, that, things close to your heart, those work really well.
Everything else, somewhat debatable.
Exactly.
Yeah. So that's what I did this weekend. I got a hole in my head.
A new hole. Wow.
Yeah.
And do y'all want to do some questions?
Yes.
All right. Here's one of our questions for today. I found out I had PCOS in February 2023 by my PCP. I was referred to an OB-GYN and saw him in June 2023. I started letrozole in July and had one cycle of 2.5 milligrams and didn't ovulate. Prescription was increased to 5 milligrams and I've ovulated 3 times. I'm still not pregnant. My husband and I have been trying since I stopped birth control in August 22, and ovulation was confirmed with day 21 progesterone. OB-GYN won't refer to REI until 6 cycles of letrozole and says it just sometimes takes a few cycles. What reasons could there be for me not getting pregnant? What are my odds each month as this goes on? I was hopeful that timed intercourse and ovulation induction would be enough, but I'm starting to get discouraged.
What was the age?
Yeah,
I don't have an age.
Okay.
Oh, okay.
Because generally most fertility doctors tell you, and I think I'll agree, 3 or maybe 4 times of doing letrozole is plenty. and by that time it's reasonable for you to come see a fertility doctor. I just wonder, maybe if you're really young, maybe your doctor's like, well, it's going to happen, and they're not too concerned, and that's why they're saying don't come sooner. But I mean, I think probably we would all agree, absolutely, it's time to see a REI fertility doctor.
Yeah. And when you look at the reasons why it's not working with and this is assuming you're under the age of 35, with a 12 to 15% chance success rate each month, after you do 3 months, you're at maybe, I want to say it's like 38-ish% or so. And so that's way better than the 2 to 3% that you were at ahead of time, particularly if your ovulation was uncertain. But that is nowhere near 100%. And so most of the time, if someone's not pregnant, it's just because the odds are not particularly favorable for that. They're better, but better is different than good.
So kind of thinking of a happy medium and not wasting time and effort, you may want to think about that. First of all, depending on where you live, it may take a month or two to get in to see your reproductive endocrinologist.
Yeah, that's true.
So you might want to call, make an appointment, and while you're waiting, keep on doing some letrozole cycles. It's not going to hurt anything. And in fact, we may get some more information. And if perhaps you could, in the meantime, get an HSG or the dye test of your fallopian tubes, that would probably be a big help. And sometimes when you call to make your REI appointment, you may want to ask if your partner can go ahead and get a semen analysis. So if we know that you're ovulating, your tubes are open, and he's got good sperm, then we really need to just fix out, got my tongue all tied there. Make sure that your ovarian reserve is doing good, and then they can come up with a treatment plan pretty quickly.
Yeah, that'll kind of help expedite things. That's a good idea, because it's always nice, I think, when patients come to see us and they've already had a lot of those things done, and then we can jump right into what we want to do for treatment quickly.
Yeah.
Good stuff. Let's do one more.
Yes.
Hello, and thanks for everything you guys do. So thank you so much. That's very sweet. I'm a 35-year-old with AMH of 2.99, AFC 20, subclinical hypothyroid, mild adeno, and elevated prolactin, taking Synthroid, Agestin, and starting cabergoline soon. First egg retrieval, 8 retrieved, 4 FERT, no blasts. I switched clinic for second egg retrieval, 10 retrieved, 8 FERT, again no blasts. Used the antagonist protocol both times. I'm much happier with my second clinic because that doctor found the adeno and made suggestions to better control my hormones, but unfortunately, he's against using Omnitrope. Do you think it's unethical if I find another RE, a second opinion telehealth, who's willing to prescribe it so I can use it for my next egg retrieval without telling my doctor? I just want success in a baby. Thanks.
So, I mean, there's some other options other than Omnitrope. I mean, certainly, bottom line is, if you want to switch to a different doctor, that's your prerogative. I don't think that's unethical at all.
But I think what she's asking is it wrong to get that prescribed by one doctor and be doing a cycle with a different doctor, and that doctor not knowing she's using an additional medication?
Oh yeah, no, don't do that. That's not smart. That's not good. I mean, you need to have your treatment with one person so that one person can coordinate everything. So yeah, sorry, I misunderstood the question.
I'm also not sure that I can think of very many docs who'd be really okay with, I'll give you the Omnitrope without them being the one controlling your IVF cycle.
I agree.
That's a med that's given in such specific reasons that a lot of people won't give it unless they know, okay, this is the time frame and we're good.
So one thing you may want to think about is if you're thinking about going to this third doctor so that you can use Omnitrope, which I personally think is a good idea to use Omnitrope considering your past 2 egg retrievals, is a lot of people make those types of decisions because of distance. And so if this is a place that you can at least get to for egg retrieval day and for embryo transfer day, most fertility clinics in the US will do what we call outside monitoring. So you can monitor your cycles at the clinic that you've been getting care at and just get your ultrasounds and possibly even your blood work there. But the other doctor is calling the shots. So they're deciding what your medications are. They're deciding when you're getting triggered. They're the ones who are taking care of any complications. So you can get your monitoring close to home, but potentially see this other physician who you may feel more comfortable with their treatment plan, but you need to be able to get there for egg retrieval and embryo transfer.
Well, and I'd say one of the things to consider is antagonist cycles are not the only type of stimulated cycles. There's some different tweaks and things that can be done. Day 21 Lupron cycles, microdose Lupron flare cycles. So there's some other different ways of doing stimulated cycles that may be beneficial too. So I don't think the answer is all just Omnitrope. I mean, maybe you do that, But I think it's worthwhile to discuss, maybe with somebody else about what are some other ways to stimulate me that might be better.
An omnitrope is unlikely to hurt. It's just the data is also not super likely to help. I mean, there's a reason that we don't automatically do it on all of
Everyone.
our
Yeah,
patients.
that's
Like
right.
if we knew that it worked, you better believe that we would all pull it out at every opportunity and twice on Tuesdays. But because the data is not like it's not super
It's growing.
concrete.
It's
It's
growing.
it's
But it's still
growing.
not there.
It's
But
growing. It's not there. But in somebody who's had 2 cycles that haven't made it to blast,
yeah, I mean, I don't think you have anything to lose besides money on a treatment that may or may not work, but money can be earned again. And I don't think it's going to cause any physical or like health related harm.
but the big thing is don't take a medicine under the care of one physician and not
That's
letting the
right.
one who's
Yeah.
actually in control of your
Yeah.
cycle not know about it.
Yeah.
Yeah. That does
And
not bring for a trusting relationship in either
Mm-mm.
direction.
right. But another thing you can do is you can talk to your physician you've been working with and say, "Hey, listen, this is something I feel strongly about. If I have another physician who's willing to prescribe it, are you okay doing that concurrently with your treatment cycle?" Because I mean, I have patients, I don't really necessarily, I'm not really into, taking all the IVIG for natural killer cells and things like that. But if I have a patient who's seeing a doctor who is going to be in control of that and they are responsible for that treatment, I don't necessarily mind if they're doing it concurrently with me, with the understanding of that doctor's in charge of that. I'm in charge of this, but I do need to know everything that's going on.
Yeah, I think that's a good point. Sometimes the lines get a little gray though, and I used to kind of do that too. And now I'm kind of like, if you're going to have a treatment, you either do it with me or you do it with somebody else because it just gets really confusing sometimes. And
It
then
is more
patients are
challenging.
not. Yeah, and so I think it's just better. I personally, not everybody feels the same way, but I think it's personally for I'll do this treatment, or you will go to that other doctor and have them do that treatment.
Mhm. There's something to be said for having one captain of the ship,
Yeah,
because invariably, if you put two REIs in the same room, you're going to get three opinions.
yeah.
And when you're making decisions about we're going to trigger now, you're going to take this medication, you're going to take that
Mhm.
medication, you want to have faith in the captain who's in charge of everything, because you don't want somebody to introduce doubt at the last second of no, you should really wait one more day. Like that's a
Mhm.
terrible idea for you, both docs, probably your nurses as well who are working with you. Like it's a setup for badness.
It adds
Mhm.
stress to the situation.
Yeah, yeah. So okay.
All right.
All right, so today what we are going to talk about is fibroids, also known as myomas or leiomyomas or big goombas at times. And so with fibroids, how common are fibroids, first of all?
So fibroids are very,
Really common.
very common.
If you get old enough, everybody gets them just about.
Like literally there's actually a cadaver study that evaluated women after they had passed away, and 80% of women at the time that they pass away have a fibroid. So the interesting thing about fibroids is they're like real estate: location, location, location.
Yes, absolutely.
So if we're going location, where are fibroids located in general?
In the uterus.
Excellent. Okay. So why do we get so persnickety about location? So the uterus is the uterus, right? Why would it make any difference
Because
if it's in the uterus
there's
or
different
otherwise?
parts of the uterus, and where a fibroid is in that uterus can make a difference from the fertility perspective. So generally speaking, sometimes we have fibroids that are kind of sitting on the surface of the uterus. Those fertility wise, most of us don't think really make a difference. Okay. There can be fibroids
Outside surface, right?
the
Outside
outside
surface.
surface of the uterus. And then there can be fibroids that are in the muscle of the uterus. Okay. Most of those are not going to cause a fertility issue, but the ones that have some involvement in the endometrium, so the inside of the uterus, the part that you shed with each period or where a baby actually ends up being in the uterus, those are the ones that we focus on.
And one thing I think we need to point out, because when I tell a patient, oh, guess what? You have this growth in your uterus, their eyes get really big and they get really nervous. And, we know when we say that, we sometimes forget to mention this to you, that like 99%, 99.9% of the time, they're completely benign. We're not worried about them. We're not worried about them being cancer. I mean, rarely there is something called a sarcoma that can be, fibroid can kind of turn into that, but those are extremely rare situations. And so most of the time we see them, we're kind of like Susan said, it really depends more on the location. Not that you have them, but really the location that's more important than anything else. There's no reason to just jump right in and cut one out just because you have it.
So what
In
are
most
they made out
situations.
of? What are
They're
they
made
made
out
out
of one single cell that grows and grows and grows and grows, and we don't really know why. I mean, I'm sure people are doing research on that, but I don't think anybody really knows why. They just continue to grow. But they're really cool when you're dissecting them out surgically, because they're almost like a little hard ball. You sometimes you have to cut into the muscle of the uterus, and when you get to the fibroid, you literally can take your finger around it and just dissect it right out, and it comes out as a little ball. So it's just a little hard ball of tissue.
The way that I compare what a fibroid feels like is if you cut a tennis ball and you take out the inside of a tennis ball and it's firm but squishy, that's exactly what most fibroids feel like.
Yeah.
So a lot of our patients have polyps too. Are fibroids and polyps pretty much the same thing?
No.
No, I say a fibroid is like hard like your chin, and a polyp is kind of like a skin tag. It's squishy, and it's much easier for us to remove that. We do much less damage. And typically polyps only grow inside the uterine cavity, or in the canal between the uterus and the vagina. So they grow in a little bit different place than fibroids do generally.
But we often treat them similarly. So
Yeah.
because they're both interfering with the lining of the uterus, we know that they can cause issues with implantation. So an embryo actually sticking to the uterus. It can also increase the risk of miscarriage. And it can both of them can make you have funky bleeding that can be a pain.
Yeah, we kind of sometimes I'll tell patients it's kind of like an IUD, and a lot of people are more familiar with IUDs because that's a more common form of birth control now than it used to be. But essentially, one of the primary mechanisms of an IUD, I mean, there's some certainly that have, hormones attached to them or secrete hormones, but IUDs, one of the primary ways they function is they cause constant friction and irritation inside the uterine cavity. And that's kind of what we think about a fibroid too, that it causes constant friction and irritation, and just your little embryo just doesn't want to implant. Inflammation's bad in your heart, it's bad in your gut, and we know it's bad in your uterine cavity as well.
So if 80% of people have fibroids when they die, do 80% of people have problems from fibroids when they're trying to make babies?
No, it's actually one of the rarer things that we have to deal with, fortunately. And so, I think if you're coming to your fertility doctor and you have not had an ultrasound, a fibroid is not one of the things we expect you to have. If you have one, it's usually not a big deal. And if we'll
It's
do some
little, yeah.
evaluation to figure out if it's a big deal or not. But it's not one of the top causes necessarily of fertility challenges.
So who are the people where we really do get persnickety about the fibroids and where they're located, and do they need to come out and all of those things?
Those are the fibroids that are really close to the cavity. I always say it's like if you take your fist and punch it into a balloon, kind of like the balloon, if the shape changes with where the fibroid is, if it changes the shape of your cavity because it's punching inside the cavity, those are the ones that we typically want to remove.
So how do you diagnose that a fibroid's there?
So usually the first way it's diagnosed is with an ultrasound. So usually a vaginal ultrasound. If you haven't been to a fertility doctor before, one thing that's good to know is pretty much all the ultrasounds we do are inside the vagina. And the reason is because everybody's like, oh, you're not going to do it on my tummy. And I'm like, nope.
No.
So we actually get much better images of your uterus and your ovaries with a vaginal probe ultrasound because we can get closer to the actual organs that are of interest. And so we'll do an ultrasound, and there's a lot of things we can diagnose with just a regular ultrasound. We can diagnose shape, okay, and general position of a fibroid. We can get an idea sometimes if a fibroid has been really painful, it might show us signs that it might be degenerating or changing its structure inside of you, and that can be seen. But after that, there are some other imaging modalities that we might use. So I'd say the most common is a saline ultrasound or a sonohystogram. And that's a special type of vaginal ultrasound where we put a tiny little catheter in the uterus, gently inject some saline, and which is just salt water, and we do a vaginal ultrasound at the same time. And that's where we're able to get those images like what Abby was talking about, where you have a balloon and it's punched in, and we'll be able to see if that fibroid is actually interfering with the lining of the uterus. Now, in cases when people are coming in for fibroids for not necessarily fertility reasons, but because they're having other symptoms like pain, pressure, issues with their bowel or bladder, oftentimes an MRI is used for us to get an idea of size and position of the fibroids. But usually when we're talking about fertility related issues with fibroids, ultrasound or saline ultrasound are going to be the main go-tos.
Yeah, I think the exception to that is if they're really big fibroids, like outside the pelvis, and we can't even really see them very well, or if you have a lot of fibroids. Every now and then, my ultrasonographer, who's wonderful, will be like, they need an MRI because she can't see the endometrium, because fibroids create shadows inside the uterus. And so sometimes if there's a lot of fibroids or several large fibroids, you just can't get a good picture of them. And it's really helpful to see the soft tissue better. Typically in those kind of situations, if you're going to get an MRI, lots of times those are fibroids that probably do need to come out before you get pregnant, unfortunately.
So if you've got one of those fibroids, it's on the inner lining in the endometrial cavity, and it's poking in and just causing drama, how do you get rid of it?
So
Well, if you're really, go ahead.
Okay. So the procedure that we usually use is something called a hysteroscopy. Okay. So I did not say hysterectomy, which means taking out your uterus. Okay. Hyster is a word that means uterus, and oscopy means taking a look. Okay. So essentially you go for this type of procedure. It is the type of hysteroscopy that you're going to go to sleep for. Okay. You're not going to do this in the office of your doctor. You're going to go to a surgery center of some sort. You're going to undergo anesthesia. And then a lot of times we may inject a little bit of medicine into the uterus to help reduce any bleeding that might happen. And then we introduce the little hysteroscope, which is a long tube, which is about the diameter of a pencil, inside the uterus, and we can see directly what is going on. And so we'll be able to see the lining of the uterus. We should be able to see the ostia, or the openings to the fallopian tube, and we'll be able to see the fibroid, if it's interfering in the lining of the uterus, kind of punching out into that endometrial cavity. We then have in the hysteroscope, we can use a couple of different types of shaving devices that we gradually shave off the fibroid and ideally remove it in its entirety. Now, one thing to know is depending on the size and the hardness of your fibroid, which is the hardness, there's no way for us to know until we're in there.
That's right.
When we're doing this type of surgery, we're usually using saline. So that salt water we were talking about earlier. And there's a certain amount of saline that can go in, and we watch how much goes in and how much comes out. But there's a level that we need to stop because it might be too much for your body to compensate for later. So sometimes we get to a point in removing a fibroid because of that, or maybe we just can't enucleate or kind of get the rest of the fibroid out in this particular procedure. We stop and perhaps come back, do another saline ultrasound, and see if we might need to do another procedure. So this is a big difference between polyps and fibroids. If you have polyps, you may have recurrent polyps, but we're not gonna have to come back to get the polyps from this time. Whereas fibroids, there are a reasonable number of times that you may need to have what we call a second look procedure.
Yeah, and I kind of say it's like if you think of the fibroid as a rock, if more than half of the fibroid or the rock is up in the cavity, we can see that pretty easily and get rid of it pretty easily. The tricky ones, like Susan said, are the ones that are bigger ones, or the ones that are buried deeper. And it's always a challenge if the fibroid's just poking into the cavity. It's like, well, is it worth the risk of damaging the endometrium to get the fibroid out? when we know it's probably going to be a 2 surgery procedure, or do we just kind of say probably it's not poking in there enough? And there's kind of shades of gray in terms of what we think with fibroids, but generally the deeper the fibroid is, the harder it is to get it out in one sitting if it's bigger and if it's buried pretty deeply.
So the submucosal fibroids are pretty straightforward. You see them, they got to come out.
So submucosal are these ones that are poking out into the lining.
Mm-hmm. And so with the other fibroids, if they are poking out in the other direction, meaning they're, kind of in the wall, but for the most part, they're on the outside of the uterus, those tend to be pretty easy because unless someone's having symptoms from a fertility perspective, we generally don't really care about those. There's a third location, which is in the wall of the uterus, that can be a little bit trickier because if they're definitely poking into the cavity, okay, that's when we've got bigger issues. If they're definitively not, and they're poking out on the opposite side, that tends to be better. But what are the things that we consider when we're trying to decide, does this intramural fibroid, so just solidly within the wall of the uterus, does that one need to come out, or is it fine to stay where it is?
Well, I don't think anybody really definitively knows that answer. I think data has shown that probably 4 centimeters is about the size where if it's much bigger than that, you should at least consider having it taken out. Now, a lot of times what I'll do, I'll have the patient talk to their OBGYN and see how comfortable they are. In my experience, most of the time, the OBGYNs are like, it's fine. It doesn't need to come out. I think the other things to consider, though, is if the patient's having pain and we think it's related to the fibroid, if she's having other symptoms like really heavy periods or really bad cramps, then, I think that's a reason to consider taking them out. But generally, if they're not causing other problems, most of the time we kind of just watch them. If they grow quickly, we might want to take them out. But other than that, most of the time we kind of leave them in.
So another thing to consider if you have a fibroid is that if you have to have a fibroid removed abdominally, whether it's a big open procedure or you have it removed with a robotic surgery or a laparoscopy, if we're cutting into the muscle of that uterus, in almost all cases, you're going to be recommended to have a C-section and they are not going to want you to labor. So if you have a fibroid that you're like, oh, do I want to have it out? Do I not want to have it out? And it's one of these that has to be not removed hysteroscopically, but through your abdomen, that is something for you to consider because the option of a vaginal delivery may not be an option for you any longer.
And the other corollary to that is for most physicians that do this kind of surgery, they're going to tell you that you cannot get pregnant for 3 to 6 months. And I've even heard some doctors say a year. So it really depends on the doctor. It depends on the number of incisions, how big it is. They'll make a recommendation, but there will definitely be a time period where you'll have to wait before you can get pregnant because, it takes, even though we sew the uterus back in several layers, it still takes a while for it to reach its maximum strength after surgery. And so, that's the other thing. If you're 40 or 41 or 42 and we say, oh, you're gonna have to wait 6 months or a year to get pregnant, that's kind of a big deal.
So if someone has their fibroids removed surgically, does that mean they're gone forever and ever, amen? Never ever coming back?
No. And the thing is, especially if you have a family history of fibroids, there's people who make fibroids tend to make fibroids. So our goal is to remove the fibroid, get you healed, get you pregnant, and then moving on to the rest of your life so that hopefully those fibroids will be inconsequential.
Usually, though, if you're mid to late 30s, it's really unusual for you to develop a fibroid big enough going forward that would cause a problem. The exception would be even if it's in the cavity, even if it's small, that's a problem. But generally, the people that have to have reoperations for really big fibroids or multiple fibroids are people who have had the first surgery like in their 20s. They're just the people that really grow fibroids. And then, when they get in their late 30s, they have to have another surgery again. Hysteroscopy, the surgery that Susan talked about first, is much, much easier. I mean, nobody wants to have surgery, but if you have a small fibroid that reappears in your uterine lining, a year or two later, hysteroscopy is pretty easy to recover from. Whereas if you had to have a bigger surgery, where you had to have an open incision or robotic myomectomy, those surgeries, it would be a bummer to have two of those, because those are usually pretty big surgeries and you have to wait a long time before you get pregnant.
What's the impact of hormones of pregnancy, for example, on fibroids? Anything?
They tend to grow sometimes.
Yeah,
Sometimes
not
they stay
good.
the same. They don't usually get smaller though. You know, in pregnancy, we like to say, you know, a third get better, a third get worse, and a third, you know, stay the same or whatever. But I think generally they're going to stay the same or they're going to get bigger. And it varies from person to person. I would say getting bigger is not what usually happens, but you can have some people that during pregnancy, you can have some big growth. So it probably has to do with some specialized receptors in the fibroid for those specific individuals.
Yeah, and one side effect of that too is if you do have a large fibroid, even if it's outside the uterus and it's not treated, or if it's intramuscularly and we don't think it needs to be taken out, sometimes, and again, very rare, but sometimes it can grow quickly in pregnancy and it can cause pain if it kind of outgrows its blood supply. And that's a really tough problem to deal with for the patient and for the doctor, because if you're pregnant, we can't really go in and take the fibroid out. So we just have to treat the symptoms of pain. So the good news is that doesn't happen very often. Yeah, very rare.
Yeah. There are other ways to deal with fibroids, things like uterine artery embolizations and sometimes endometrial lining ablations and all those things. What do you think about that for somebody who wants to get pregnant?
So for those of you who are watching us on YouTube, you would have seen
We're
mine and Abby's faces as Carrie was saying those words.
No.
So those are things you do not want to do if you plan on using your uterus for reproducing.
Yeah, because it can decrease the blood flow to the lining. We worry that the baby might have IUGR. The other thing you worry about is the different types of placental problems like increta, accreta, which means the placenta grows into the wall of the uterus, and the doctor at the time of delivery can't separate the placenta from the wall of the uterus, and you have a lot of bleeding. That's kind of the other risk of doing those types of things. So generally, we don't like those. We don't want you to do those. Yeah, and they don't get rid of the fibroid; they just shrink the fibroid down, so the fibroid's still there.
All right. So that's a general good overview of fibroids. There's some nuances there that we have not totally dived into, but any other big points about fibroids we want to make sure people hear on this episode if they're just starting to learn about them.
If you're nervous about your fibroids, so if you know you have fibroids and your doctor seems like they're wanting to do something more extreme than what you're comfortable with, share those fears with your doctor, okay? And see if there's any flexibility in what are possibilities. Sometimes there aren't, okay? But, you know, definitely share your concerns because we want to do what's the right thing for you.
Yeah, and I think one other thing we failed to mention was just that, you know, with fibroids, surgically, we talked about it's typically more difficult to get them out than a polyp. That also means if we have to dig into the uterus to get the fibroid out, there's a little bit higher risk of scarring. But generally, we do these pretty commonly, and we all have the ways that we deal with those. Estrogen, sometimes we put catheters in the uterine cavity to decrease the risk of adhesions. And so I think in the hands of someone who's experienced doing this, I think your outcomes will be really good. And you know, you have to trust your doctor to really give you good information, to really, you know, you've got to really trust that they're telling you if it needs to come out, that it really does need to come out.
Absolutely. All right. That was a good episode. I like fibroids, particularly when they're coming out. Or already out, I should say.
Yes, already out.
So to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review in Apple Podcasts. We would love to hear from you. We're on Instagram, we're on Facebook and YouTube. So please stop by and give us a follow.
You can also visit us at fertility.uncensored.com to submit questions. All questions will be answered on our Ask the Doc segment. Leave us episode ideas. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.